Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. That is on a very important topic that is beyond the usual, a curious case of neonatal hypoglycemia. And for this topic, we have very eminent speaker, none other than Professor Dr. Balaji Chinnasamy sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, MRCPCH, and Professor of Pediatric Department, SRM Medical College, Chennai. So, by taking not much time to know more about this topic, I would like to invite Sir and hand over this session to Sir. Sir, the stage is yours. You can proceed from here.
Okay, thank you for the introduction. So today I have taken a very interesting case. It's rather a bit different from the normal causes of neonatal hypoglycemia. And I am a professor of pediatrics, and I also am in charge of the pediatric endocrinology clinic in SRM Medical College. At this moment, I would like to say my special thanks to Dr. Ashok. He's our professor, neonatal in charge, who has done considerable workup for this case. And since I collaborated with this case, I'm happy to share the knowledge so that it will be useful for you all. So, right, and I would like to go the discussion as well as the case presentation together. That will be more so that you will understand the context behind the evaluation and the basis, the pathophysiology. So not just the case, I will also try to give the explanation also. Okay. So we have a day one male baby who was born on 20th January through LSCS. Birth weight was not that bad, not an SGA or LGA, 2.53 kg. Indication was born through LSCS. Indication was mother having gestational hypertension. So maternal history, she was a 25-year-old primigravida. Only hypertension was the complaint. She was on labetalol, no RH incompatibility. So the baby was a late preterm delivery, not that preterm, late preterm delivery, and immediately cried after birth. It didn't need any much resuscitation issues. Apgar was 8/10, 9/10. Normal transition at birth. Vitamin K was given, and the baby was initiated on direct breastfeed. But the presenting complaint was when we were checking for the sugar, there was persistent hypoglycemia. It was asymptomatic because the child was not exhibiting any signs or symptoms, but persistent asymptomatic hypoglycemia at birth was the presenting complaint. Examination, the baby was not SGA or LGA. Mother didn't have any diabetes before. So the baby was not an infant of diabetic mother, no RH incompatibility. No other examination findings suggestive of hypoglycemia like genitalia was normal with no midline defects suggestive of panhypopituitarism. There was no dysmorphism, no hyperpigmentation as in congenital adrenal hyperplasia, no hairy pinna, no amphocyl as in Beckwith-Weidman. Abdomen, a bit of hepatomegaly was there. Liver was 2 cm below costal margin. So, but before going, we need to understand what are the sugar values we need to be worried about. So, less than 24 hours asymptomatic hypoglycemia, less than 50 can be considered as significant, and beyond 48 hours, anything above less than 60 should be considered as hypoglycemia. So, 50, 60, consider those two values. So regarding the pathophysiology behind the hypoglycemia in newborn, so glucose is the main source and it comes to the baby from the mother. It is utilized by the RBCs, brain and the muscle. So glucose is important for the RBC, brain and the muscle. And if glucose is not there, we have alternative fuels from the fat, from the adipose tissue. You have ketones forming, and that will provide the alternative energy for the brain and the muscle. Also, fatty acids also will come and it will be helpful for the muscle. So, ketone production is a very good alternative way of fuel for the brain. So, when you consider ketotic versus non-ketotic hypoglycemia, which one is more serious? So, the non-ketotic hypoglycemia, which happens when insulin is high. So that is more dangerous because in non-ketotic hypoglycemia, sugar is also not there. Also, ketones are also not there. So it can cause serious damage to the brain. So that is more serious than the ketotic hypoglycemia. So now what are the ways how glucose is produced? So one is the diet, whatever we take, the baby feeds, the baby takes the milk, so the glucose comes. When the baby is fasting, then whatever stored will start coming out. The first will be the glycogen. So glycogenolysis gives the glucose. From the amino acid alanine, gluconeogenesis happens and glucose forms. Also from the adipose tissue, the glycerol which comes out, which again through gluconeogenesis, glucose forms. And adipose tissue, an alternative pathway is lipolysis, and from lipolysis, fatty acid oxidation, and ketones are produced. But usually in the first 24 hours, what is more important is the glycogenolysis. So 50% is glycogenolysis and 30% is gluconeogenesis. The ketogenesis is not that much effective in the first 24 hours. So what are the hormones that control the adaptation? So we have almost 4 hormones that are actually protects from hypoglycemia. The cortisol, which concentrates on the gluconeogenesis, growth hormone on the lipolysis. Glucagon almost acts on all, but importantly the glycogenolysis, and epinephrine almost all except the gluconeogenesis. So there are 4 hormones, so it's very difficult. You need 2 hormones to go down to cause hypoglycemia. So usually in panhypopituitarism, when cortisol and growth hormone both are affected, only then hypoglycemia happens. Very unusual for epinephrine or glucagon issues causing hypoglycemia. So the commonest cause for counter-regulatory hormone causing hypoglycemia is panhypopituitarism, where cortisol and growth hormone both are low. Okay, and insulin is one which is going to inhibit. It is a single hormone that is against all these hormones. It is going to act against all the processes. It's going to inhibit glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. So this is the blood sugar versus the hormonal action. So to start with, when the blood sugar comes down by 80, the insulin starts coming down. Then the counter-regulatory hormones kicks up at 60, around 60, the glucagon, epinephrine, cortisol, growth hormone activated. Then you have the neurogenic symptoms like jitteriness. Then by 50 milligrams, when the sugar goes down below 50 milligram per deciliter, no insulin. Insulin will be shut down. So in a baby with hypoglycemia with less than 50, there should be no insulin detected. So insulin should not be there in the routine process. So when the hypoglycemia is there, there should not be any insulin detectable. Then once you go down further, the neuroglucopenic symptoms like seizures start developing. So how much a baby can tolerate fasting? So at least one feed skipping, the baby will usually tolerate one feed skipping, but beyond that, normally itself they will have issues with the glucose. So the transition part also you should understand. The initial 48 hours is the transition period. All babies will have a dip in the sugar level by 2 hours, and by 48 hours only it stabilizes. And this dip actually is worsened in case of preterm or SGA babies. So those babies will take further time. So usually evaluating too much in this 48 hours period should be avoided for hypoglycemia, because that is the normal transition time. Okay, so these are the routine causes for hypoglycemia: the infant of diabetic mother, large for gestational age baby, sepsis, and preterm or postterm asphyxia, and baby having micropenis, suspecting panhypopituitarism or cardiac defects. So here we have to screen the baby for hypoglycemia on a routine basis frequently, like 0 hour, 2 hour, 6 hour, 12 hour, 24 hour, 36 hour, 48 hours. So you have to screen the baby for hypoglycemia. And we need to understand the management part of hypoglycemia. So if symptoms are there or symptoms are not there, if symptoms are there, we are going to start dextrose bolus followed by glucose infusion. Then you are going to increase the glucose infusion, and till 48 hours we have to continue the fluids, and then you should start tapering. If there are no symptoms, then if the blood sugar is more than 25 less than 4 hours, and more than 35 in more than 4 hours, then oral feeds itself we can give. But if the baby has less sugar, less than 25 if less than 4 hours, and less than 35 for more than 4 hours, we have to again follow the same protocol of giving IV fluids. So our target is around 50 milligram per deciliter at less than 48 hours, and more than 60 milligram per deciliter at more than 48 hours. So with this background, and we also should know about the critical sample, which I will come back later. So with this in the background, we have this baby who had low random blood sugar at first of our life, and as we suggested, we started with a bolus of 10% dextrose 2 ml per kg was given, followed by maintenance fluid of 10% dextrose. The baby was also initiated with direct breastfeed and express breast milk, serial CBG monitoring, but showed persistently asymptomatic hypoglycemia. So we kept on increasing the GIR. So GIR was increased up to 12 milligram per kilogram per minute, which was considerably high. So usually our requirement will be around 6 milligram to maximum 8 milligram per kilogram per minute. But here the GIR requirement was more, somewhere around more than 12 milligram per kilogram per minute. So at this point, we sent a very important critical sample. So critical sample is sending the blood sample and urine sample at the time of hypoglycemia. So we have to send urine for ketones and reducing substances, and for blood, we should send for ketones, look for acidosis, sodium, potassium, and lactate, and look for a set of hormones like growth hormone, insulin, cortisol, and sometimes insulin is a bit labile, so we can look for the C-peptide levels also. And also, for further evaluation, we have to send for tandem mass spectrometry for acyl carnitine and organic acids. So this is the critical sample which needs to be sent at the time of hypoglycemia. So we send that sample, and we all know that the commonest cause for hypoglycemia is sepsis in a newborn, and we did all the workup for sepsis. We started antibiotics, but the cultures came sterile, CRP values are not elevated, and antibiotics were continued till 2 weeks and stopped. And the routine investigations were quite normal. And the most important to consider is the congenital adrenal hyperplasia salt wasting type, but here the sodium was not low, potassium was normal, bilirubin was not much elevated, calcium was normal, and the CBC is not suggestive of any sepsis. And ultrasound abdomen and echo all came out to be normal. So these were the preliminary investigations. And with regards to approach to a child with hypoglycemia, as we have sent the critical sample, we need to understand the interpretation of the critical sample. So it all depends on whether the baby has acidemia or no acidosis. If acidosis is there, how is the lactate, how is the ketones? If the lactate is elevated, then it's probably a gluconeogenic enzyme deficiencies. Lactate is elevated. Uh, and glycogen storage disorder will have this lactate increase. Then the ketones, if the ketones are elevated, then most important will be your starvation. Then your growth hormone and cortisol deficiency will also have the ketones elevated. Also, we look for the midline defects and micropenis for growth hormone and cortisol deficiency. If there is no acidosis, then we are looking for the ketones. If the ketones are reduced, but free fatty acid is elevated, then it is a fatty acid oxidation defect. If the ketones also reduced, free fatty acids also reduced, there is no acidosis, then it is hyperinsulinism. And to confirm hyperinsulinism, we have to look for the glycemic response to glucagon. So you give glucagon and the glucose improves, then again it is proof that it is hyperinsulinism. So here in our child, there are a lot of pointers even before itself towards hyperinsulinism. One is the child had some element of hepatomegaly. Mainly the requirement of glucose was very high. So usually the GAR, as I said, will be around somewhere 6 to 8 milligram per kilogram per minute. Here it went to beyond 12 milligram per kilogram per minute. So that itself is a very important pointer towards hyperinsulinism. And the other things, we almost ruled out all the other factors like GDM and sepsis. And on laboratory investigation, as we looked into the protocol, the ketones were low and free fatty acids were low. So low ketones and low free fatty acids also points towards hyperinsulinism as per the protocol. And in the diagnosis, if we have any detectable insulin, we said already that when the sugar is below 50, you should not have any detectable insulin. So if there is detectable insulin with low sugars, then that is wrong. So that also suggests hyperinsulinism. Then the response to glucagon should also be checked. You give glucagon and see if the sugar improves. That also suggests that it is hyperinsulinism. So the basic protocol is, in hyperinsulinism and fatty acid oxidation defect, the ketones will be low, less than 2 millimoles per liter. And insulin will be more in hyperinsulinism, it will be more than 2 mu per ml. Okay, and there will be a good response to glucagon. But however, there will be no acidosis and there will be lactate will be normal. In all other conditions, be it the organic acidemia, GSD1, and endocrine deficiency, the ketones will be elevated. So ketones will be elevated in all other causes of hypoglycemia. Ketones will be suppressed in hyperinsulinism and fatty acid oxidation defect. Insulin will be detectable in hyperinsulinism. Okay, and the acidosis will be there in organic acidemia, GSD1, and gluconeogenesis. Lactate will be elevated in GSD1, and there will be no response to glucagon test in all other tests except the hyperinsulinism. So based on this background knowledge for our baby, we did the newborn screening. And here the amino acid profile for amino acid disorders, urea cycle disorders came out to be normal. The acyl carnitine profile, which through the tandem mass spectrometry we said for fatty acid oxidation and organic acid disorders came out to be normal. So the fatty acid oxidation and organic acid disorders were normal. The acyl carnitine profile was normal. Okay, and other screening tests which we routinely do came out to be normal, especially the galactosemia, which is an important cause for hypoglycemia. So that also came out to be normal. So in the critical sample, what was positive was cortisol was normal, ketones were low, it was less than 2, and insulin levels were elevated, 52.56 IU per ml. And we said already that insulin levels should not be detectable in hypoglycemia. So the critical sample results were suggestive of hyperinsulinemia. So here is a case of hyperinsulinism, and we have different causes for hyperinsulinism. Usually it is transient in the case of infant of diabetic mother, RH incompatibility, and mother on sulfonylurea or beta blockers or high umbilical artery catheter insertion. But this transient hyperinsulinism usually lasts for up to a week. Then in a prolonged hyperinsulinism, where it can prolong for almost 2 to 6 weeks, as in small for gestational SGA babies, Beckwith-Weidman syndrome, asphyxia. So here usually the hyperinsulinism problem lasts up to 2 to 6 weeks. That something that is persisting even beyond 6 weeks is due to a genetic mutation. It could be due to the potassium ATP defect, GCK glucokinase mutation, or glutamate dehydrogenase mutation, SCHAD mutation. So it's all genetic mutation if the hypoglycemia persists beyond 6 weeks. And hyperinsulinism is the commonest form of persistent hypoglycemia. So any newborn who has persistent hypoglycemia, it is because of hyperinsulinism. And what are the key suggestives, as we discussed already? High glucose requirement. So here the child is requiring 12 milligram per kilogram per minute. Hepatomegaly and macrosomia, all suggestive of hyperinsulinism. So before going into the genetics, you need to understand what is happening in the insulin release, why hyperinsulinism happens in genetic defects. So we all know that the glucose enters through the GLUT2 channel, and then the glucokinase enzyme acts on the glucose, causing the glucose 6 phosphate glucose 6 phosphate, and this glucose 6 phosphate opens up the potassium ATP channel. So the glucose 6 phosphate produces the ATP. This ATP is going to open up the potassium channel, and this potassium ATP channel will cause potassium to enter inside and calcium to enter inside, and finally the insulin release happens. So glucose is the main sensor. So glucose enters through the GLUT2 channel, glucokinase converts it into glucose 6 phosphate, and that produces ATP, and ATP will cause the potassium channels to open up, and finally the insulin comes out. Also, not only glucose, the glutamine, which is a form of amino acid, glutamine, leucine, also through the glutamate dehydrogenase enzyme, again it will produce the ATP and it will open the potassium channel. Also, fatty acid, also through the SCHAD pathway, it will also open up the potassium channel. So potassium channel, ATP channel, is opened up not only by the glucose but by glutamine, glutamate dehydrogenase effect. So whenever there is a defect in either the glucokinase, where the glucose cannot act, glucokinase defect, or the glutamate dehydrogenase defect, or the SCHAD defect, all can activate continuously the ATP channel. Also, the potassium ATP channel also can get mutated. So that will be the commonest ABCC8 gene mutation, KCN11 mutation. Though these are the two that will affect the channel directly, the potassium ATP channel. Here, why it is important is the ABCC8 gene mutation that is affecting the potassium channel is diazoxide resistant, because diazoxide, the drug, acts on this potassium ATP channel. So ABCC8 gene mutation will, if it is there, then it is going to be resistant to diazoxide. It's not going to respond to diazoxide. Whereas the GDH activating defect is mild and it will respond to diazoxide. And one clue is ammonia will be increased in this group. So the glutamate dehydrogenase defect activating mutation, ammonia will be increased. So that will be a clue, and they will be responding to diazoxide. Whereas the ABCC8 mutation, which acts straight on the potassium channel, it will not respond. So the diazoxide will not respond. Okay. So these are the three different major defects with hyperinsulinemia. The KATP channel, where macrosemia will be there, it will be severe hypoglycemia, and ammonia will be normal, and surgery is the major final output. They might not respond to diazoxide, so you have to go for surgery. Whereas the glucokinase and the glutamate dehydrogenase are severity wise, it is mild, and ammonia will be high in glutamate dehydrogenase, so that's a very important clue, and they respond well to diazoxide. So with this, and also one more important thing you should understand is this defect, from where it is inherited. So this ABCC8 mutation, the KATP mutation, from where it is inherited. If it has been inherited from the father, then there is a high chance of this whole problem to be a focal disease. So the hyperinsulinism will be in a focal area alone. So if the mutation is inherited from the father, then the hyperinsulinism is going to be a focal disease. So it will be very good for resection. So surgically it is amenable. Okay, so so you have to do the genetic analysis for the father also. So that's why. However, if it is not from the father, not paternally inherited, then it is going to be a diffuse. Then you have to go for the total pancreatectomy. So from where you are inheriting, it is very important. And also, if it is a somatic defect, again, it's going to be a focal disease. So if it is going to be KATP channel defect, it's very important to differentiate whether it is focal or diffuse. One clue is looking for the mutation in the father. If he also has mutation, 90% it's going to be focal. So if it is focal, then a small part alone you can do the resection. So that is the advantage. And whenever hyperinsulinism is there, the approach is you give a diazoxide trial. If they're responding to diazoxide, then probably it is glucokinase or glutamate dehydrogenase defect. So there you have to do a comprehensive genetic testing for all the mutation. If it is going to be diazoxide unresponsive, then probably it is going to be a KATP channel. So very important to immediately do the genetic testing for ABCC8 mutation, the channel mutation, and also do it for the parents. And if father it is positive, then go for the F-DOPA PET CT to look for where exactly the hyperinsulinism cells are there. If it is focal, then you can do a resection, and partial resection will give a good cure. If it is diffuse and not responding to medicines, then you have to go for a 98% pancreatectomy. So here in our case, the management of hyperinsulinemia is diazoxide was started on day 4 of life. Because of the hyperinsulinemia, diazoxide was started, and we said already whether it is going to respond to it or not. Based on that only our management goes. So here the hypoglycemic episodes persisted in spite of diazoxide, and then we gave then the alternative will be octreotide and hydrochlorothiazide. So we started injection octreotide from day 6 of life, since there was no response to diazoxide. So right from there itself we know that it's probably going to be a KATP channel mutation. And then baby tolerated, feeds well, IV fluids were tapered and started on breastfeeding. The baby was discharged on both diazoxide and octreotide and waiting for the whole exome sequencing to come. And after around 1 month, we got the whole exome sequencing report. So as expected, it came out to be ABCC8 mutation. ABCC8 mutation is a cause for hyperinsulinemia. We discussed already, it is the potassium ATP channel defect. So it's not going to respond to diazoxide. Okay, so in view of the genetic testing indicating a diazoxide resistant pattern, so injection octreotide was hiked up to 3 times daily. So we increased the octreotide because we know that it's not going to respond to diazoxide. And we stopped diazoxide and hydrochlorothiazide. And octreotide dose was somewhere around 7.5 microgram per kilogram per day. It was on the lower side only. And the baby was discharged at 1 month of hospital stay. And now there is a twist in the story. At the 8th week of the baby, the baby was on octreotide alone, and the baby was not on diazoxide. The baby was brought with history of yellowish discoloration of the sclera and high colored urine. The baby was on direct breastfeeding. So the baby is presenting with jaundice and high colored urine, suggestive of direct hyperbilirubinemia. But there was no history of pale colored stools, no abdominal distension, no edema, no history of fever, vomiting, irritability, no signs and symptoms of liver cell failure. Baby was evaluated for neonatal cholestasis, and blood culture there was no growth. Urine culture there was no growth. Hepatitis B surface antigen was non-reactive. CMV virus was negative, and there was no hypothyroidism which can cause cholestasis, and there was no acidosis in the VBG. We even went for the ultrasound to rule out the other causes of cholestasis, surgical causes of cholestasis like biliary atresia, choledochal cyst, that was ruled out. Optal evaluation also, there was no cataract or chorioretinitis. So we didn't get much for the reason for the cholestasis in spite of evaluation. Although the bilirubin was 19 and direct hyperbilirubinemia was there, and SGOT, APT was elevated. OT was elevated more in the thousands than SGPT. SGPT was 256. And in spite of all this elevation, there was no feature suggestive of liver cell failure. So it's more of SGOT that is elevated than the SGPT. And we often, so in the management, the second part of the management, so we continued the direct breastfeeding and top feeding, and sugar was on the lower side. So we again restarted maintenance fluids with dextrose containing fluids, but the child was maintaining sugars with just the routine maintenance. We added for the fat soluble, for the cholestasis, the fat soluble vitamins, Aquasol, Evion, vitamin D, Hutka, MCT oil. Okay, we gave all those. And there are literature suggestive that octreotide associated cholestasis and hepatitis is possible. So that is one possibility. Octreotide induced cholestasis, octreotide induced hepatitis. especially when SGOT is more elevated than the PT. So it's not suggestive of the liver failure, liver damage. So it's more of the drug-induced liver injury where SGOT will be more elevated. So suspecting the drug-induced injury, we stopped octreotide. Octreotide was withheld, and the child was maintained on IV fluids. And liver biopsy was also planned, and we took opinion from the pediatric gastroenterology. And further course with the pediatric gastroenterology. So we followed up the LFTs serially, and ultrasound was normal, and LFTs were kind of improving slowly. Hence, liver biopsy was deferred by the gastroenterologist, and all other parameters like ANA, AS, NT-LKM, so other features suggestive of autoimmune hepatitis all came out negative. But problem is now we don't have diazoxide, and now octreotide is suspected to cause cholestasis. So we have to stop. We cannot give octreotide also. So what options are left? So we tried cornstarch 1 gram per kilogram in expressed milk and gradually increase to thrice daily. So when other options are not there, so we can give uncooked cornstarch 1 gram per kilogram in expressed milk. And plan was, as already discussed, if there is a ABCC8 mutation, if it is not responding or drugs are not available, then you have to look whether it is surgical options have to be, we have to look for surgical options, and if it is focal or not, that is the key. So dopa pet has to be planned. So the plan was, if the child doesn't respond to cornstarch, we have to go for the dopa pet. And other alternative, although it is not approved, like sirolimus can be tried. And we gave advice to the parents to give glucagon whenever hypoglycemia is there, glucagon 0.3 milligram. So that was the case. So this is the final. So far we discussed about an interesting case of neonatal hypoglycemia, where we had to suspect hyperinsulinemia, and hyperinsulinemia, it doesn't respond to diazoxide, then it responded to octreotide, and genetic mutation came out to be the potassium ATP channel mutation, ABCC8 mutation. Then the child had a side effect of octreotide. Maybe we are not very sure. Even the parents were also giving history of giving alternative Ayurvedic medication weekly once. They used to go to some and take some medication. So maybe it could be the Ayurvedic medication also as a side effect. We are not very sure. But once there is a doubt, we cannot give the octreotide. So at present, the child is maintaining well with the cornstarch alone. So plan was to go further evaluation if the child doesn't maintain the sugar levels. So a final summary of the whole another 5-10 minutes how to evaluate. So when will you work up? So whenever the hypoglycemia persists beyond 48 hours, whenever the GIR requirement is more than high, more than 12 milligram per kilogram per minute, and you're not getting any risk factor at all. The baby is not LGA, so the baby is not preterm SGA. So then you have to evaluate in detail for the hypoglycemia. So what questions will you ask in the history? What is the birth weight? The birth weight is low. That can be because of prolonged hyperinsulinism as in SGA. The birth weight is high. It could be infant of diabetic mother or Beckwith-Whiteman syndrome or KATP defect. The birth weight is normal. It could be due to the endocrine as in the cortisol or GH. The glucose requirement will help to differentiate. Normally, the cortisol growth hormone and all will have 6 to 8, 6 to 10 milligram per kilogram per minute. When the requirement is high to the tune of 12 milligram per kilogram per minute, it is due to the insulin. And similarly, early onset is suggestive of hyperinsulinism or hypopituitarism. After you start feeding, if there is, then it is due to galactosemia or organic acidemia. In examination, if hepatomegaly is there, it is suggestive of hyperinsulinism, Beckwith-Whiteman, or galactosemia. Micropenis is suggestive of hypopituitarism. Pigmentation is suggestive of 21-hydroxylase deficiency. Cholestasis is there, it is again suggestive of hypopituitarism and galactosemia. Cataract is there, it's suggestive of galactosemia. So critical sample is very important, we discussed already. So ketones and acidosis you will look, and also the growth hormone, insulin, and C-peptide. and also for the acyl carnitine and organic acid. So remember, in hypoglycemia, insulin should not be detectable. So that's an important point. So this is the interpretation. So insulin should not be detectable. If insulin is detectable and ketones are not detectable, then that is hyperinsulinemia. And for cortisol and growth hormone, cortisol, if it is less than 550, growth hormone less than 10, that suggests that pan hypopituitarism. And lactate, if it is increased, then that is suggestive of glycogen storage defect or other gluconeogenesis defect. Okay. So ketones are the key. Low ketones are seen in hyperinsulinism and fatty acid oxidation defect. High ketones are seen in other causes of hypoglycemia, as in glycogen storage, organic acidemia, and starvation. So when will you suspect, when will you confirm hyperinsulinism? Confirm by the glucagon test. You give glucagon, and if the sugar increases, then it is suggestive of hyperinsulinism. And these we discussed already. So ketones are low in hyperinsulinism. Ketones are high in other conditions. And glucagon response is good in hyperinsulinism. And your insulin will be detectable in hyperinsulinism. In all other conditions, insulin should not be detectable. So the approach we discussed already. So in hyperinsulinism, so there will be detectable insulin, ketone will be low, free fatty acids will be low, and glucagon, there will be a good response to the sugar. Sugar will increase with glucagon. And hyperinsulinemia approach, we said, so first to rule out all the transient causes, then try to look into the ammonia level. If ammonia level is high and it is responding to diazoxide, probably it is a glutamate dehydrogenase type of defect. If ammonia is normal, still you go with the diazoxide trial. If it is responding, then probably those are other conditions like the glucokinase. If it is not responding, probably it is a potassium ATP channel defect. Better do the dopa PET to look for whether it is focal or diffuse, because in focal it is resection and it is amenable, permanent cure is possible. If it is diffuse, then you have no other go. If it is not responding to medication, you have to go for a 95-99% pancreatectomy. Regarding management, we discussed already. You start with bolus, dextrose bolus, then IV fluids, then you increase the infusion rate accordingly. And remember the target, more than 50 at risk and more than 60 beyond 48 hours. And these are the mechanisms I think we discussed already. So glucose through the GLUT and glutamate dehydrogenase and SCHAD pathway all can finally, it will stimulate the potassium ATP channel. Diazoxide acts on the potassium ATP channel. So if there is a potassium ATP channel mutation, as in ABCC8 or KCNJ level mutation, diazoxide is not going to work. And if diazoxide is not going to work, then octreotide, which is going to prevent the insulin secretion, that can be utilized. And glucagon also can be utilized as an anti-insulin effect. So these are the drugs which we use. So the diazoxide, which is 5 to 20 milligram per kilogram per day, which is a potassium channel opener. So fluid retention is the side effect, and we have to add thiazides or any other diuretic for that. Nifedipine, it's not that well proved, but it is a calcium channel blocker, just like potassium channel ATP. Calcium channel is affected, and so it might work. Octreotide is the only option if diazoxide doesn't work. So it is given 10 microgram per kilogram 12 hour. But tachyphylaxis is the main problem. NEC tachyphylaxis. The tachyphylaxis means it's not going to work suddenly. It might not respond. And glucagon might be used as also an insulin antagonist. Again, tachyphylaxis is the problem. So the final take-home points are, in all sick neonates, to look for the blood sugar. Hypoglycemia beyond 48 hours is significant. That is the transition point. Till 48 hours, the adaptation takes time. Beyond 48 hours, it's significant. Ketone is the most important investigation. Ketones is suppressed, insulin is detectable, then it is hyperinsulinemia. Ketone is elevated, then it is all other conditions. So ketone is the most important investigation. And immediate treatment we have to do for symptomatic cases. You give IV bolus. So immediate treatment for symptomatic cases. And if it is hyperinsulinism, the requirement will be very high, the glucose requirement. And response to diazoxide is the clue to the type of hyperinsulinism. If no response to diazoxide, then probably it is a potassium ATP channel defect. And if it is a potassium channel ATP defect, then octreotide is the option. And look for whether it is focal or not. If it is diazoxide unresponsive, then look for whether it is focal or not. One clue is looking into the paternal genetic mutation for the same ABCC8 and KATP channel mutation. Look into the father. If paternally inherited, 90% more probability that it is going to be focal, and your FDP PET, that will be helpful in imaging the pancreas whether it is focal. Focal, you do the resection, you get all right. And here in our case, side effect profile of octreotide is also very important. So we had to stop because of the hepatitis. Okay. Thank you. Thank you for listening. I'm happy to answer any questions.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yeah.
First question I can see, sir. What are the common risk factor for neonatal hypoglycemia, and how would you identify at risk infant immediately after birth?
Yeah, so that's what we discussed already. No, so the common risk factors are the baby weight. So weight of the baby is very important. So mother is a diabetic. So then the infant of diabetic mother. So the large for gestational age baby. So is the baby large for gestational age is a risk factor. Then preterm babies. So most of the glucose transfer happens in the last trimester. So preterm babies are a very important risk factor. So preterm babies, they are at risk. Then also the SGA babies. So SGA babies also will have hyperinsulinemia, transient hyperinsulinemia will be there. In addition, all the babies with birth asphyxia. So birth asphyxia is also very important. Then RH incompatibility is a very important cause for hypoglycemia. And any baby with micropenis and ambiguous genitalia. So all these babies also we need to screen, and sepsis. Okay. Yeah.
Thank you so much, sir, for sharing your expertise on that question. We have another question, sir. Describe the step-by-step management of systematic neonatal presenting with blood glucose level of less than 30 mg/dl within the first hour of life, sir.
Systematic management. So that's what we discussed in that slide. It all depends upon whether the baby is asymptomatic or symptomatic. So if the baby is symptomatic, like the baby has the jitteriness, seizures, and the baby has symptoms, then we have to start with the IV bolus of dextrose, so 2 ml per kg of 10% dextrose. Then you start the maintenance dextrose fluid, 10% dextrose. Usual typical maintenance requirement will be around 6 milligram per kilogram per minute, and depending upon the condition, you keep increasing the GIR, 6, 8, 10. So remember, as long as you are going to increase the requirement, then probably you are going towards hyperinsulinemia. Probably you are going to hyperinsulinemia. In asymptomatic hypoglycemia, we discussed already that even if no symptoms are there, but if the blood sugar are less than 25 or less than 35 for more than 4 hours, then you have to start the same process. But if the sugars are on the higher side and the baby is asymptomatic, then you try to give the oral feeds. So that's what's the discussion.
Thank you so much, sir, for sharing your insight on that question, sir. I hope it will be helpful to all the participants who have joined. Sir, I can't see any further questions. I hope you have done justice to this topic. Sir, as there is no more questions, with all your permission, shall we conclude this session for today?
Okay. Thank you.
And
Thank
thank
you.
you
Thank
once
you for
again, sir.
giving us. I thank AJCP for giving the opportunity to share the case. It will be. I
Welcome,
hope it
sir.
will be of useful to all the
Yeah,
doctors.
correct, sir.
Thank you.
And we would like to see you in future also with different topics, sir. Till then, take care of yourself. It was a great honor to have you on our platform, sir. Thank you.
Thank you. Thank you. Thank you.
Welcome, sir.